we have had a lot of good programs here over the years. This is one that I personally consider one of the 5 most important. We have all gone to other programs, have been here for programs where people have talked about what you do for high blood pressure, diabetes, common kinds of things. We've never had a program where we actually are going to save lives. We are going to teach you, our speakers are going to teach you what to look for in early signs of stroke, what to do about it, and what they do about it, and how literally to save your brain. All of us think a stroke comes on and it's there and you can't do anything about it. That is not true at all. It's something we're going to learn tonight. And our 2 speakers do different things and they work together. Dr. Sammy Pishandiad is an assistant clinical professor of neurology at Weill Cornell, and he is the director of the Mobile Stroke Team Unit. Mobile Stroke Team Unit, you'll find out tonight. This is only the 2nd one in the city, one of the few in the country. It's going to go any place in Queens. It's really fascinating. Dr. Srikanth Bodhu is the guy who fixes your brain or prevents the brain from getting messed up by doing interventional neurology. He is an interventional radiologist, not in the radiology department, but an assistant professor of neurosurgery at Weill Cornell Medical Center. Please pay very close attention, take notes on your pads, because this is going to be very important and literally brain-saving and life-saving.
Thank you very much for that warm introduction.
Please save your questions for the end.
Yes. Thank you very much. As he said, I'm Sammy Pishandiad, Dr. Sammy Pishandiad, Assistant Professor of Neurology at New York Presbyterian Queens and Site Director of the Queens Mobile Stroke Treatment Unit, which we're very excited to talk about. And we'll start right away. Okay? Nothing to disclose. So just a brief outline of what we're going to talk about. Before we get started, we're going to give you some numbers about the stroke statistics, stroke epidemiology, how many people in the United States are affected by strokes. We're going to talk about what exactly is a stroke. There are different types of strokes, and we do different things about each type of stroke. All right? But most importantly, besides knowing what a stroke is, you have to know what the signs of the stroke are and what to do if you are experiencing signs of stroke. Not only yourself, but you, your family, friends, loved ones, so on and so forth. One of the big take-home points that I think Dr. Bodhu and myself are going to stress throughout this lecture is time. Time is of the essence. Time is brain. Time is of the essence. You don't want to wait on anything. Time. Keep that in your head for now. And the last few minutes I'll talk about our mobile stroke treatment unit, which we're cutting down the time to treatment, which I'll explain is extremely important. So some of the figures in the United States. So somebody has a stroke very often in the United States, about every 40 seconds. And it kills somebody almost every 4 minutes, all right? So think about this 45-minute talk, this hour talk, how many people are experiencing strokes, how many people are dying from strokes, and think about those numbers and what we can do to possibly prevent those and help those patients out. It accounts for 1 out of every 19 deaths in the United States. It's the 5th leading cause. Behind heart disease is number 1, cardiovascular disease number 1, cancer, stroke is number 5. Even though it's the 5th leading cause of death in the United States, worldwide it's number 2. Okay? And even though patients may not even pass away from strokes, it is the number 1 cause of disability and morbidity. And what we mean by morbidity is a patient is not able to do the same things they were able to do previously. They're disabled. It is the leading cause of disability in the United States. And look at that number, 34 billion. I don't even know what that means, but it's a really, really high number, right? $34 billion is a lot of money. Not too much?
Nah.
Nah. You want to throw me some? You want to throw me a little bit of that money?
Selling lotto tickets tonight?
Okay, so before we talk about what a stroke is, we need to understand what the brain does, okay? Very generally, a stroke is a heart attack of the brain. It's a blockage in one of the vessels. You're not getting oxygen to your brain, okay? What does your brain do? Your brain does everything. Okay? It controls language, it controls comprehension, it controls your strength, it controls your thoughts, your emotions, your sensation, your balance, your vision. Anything that your body does is controlled by the brain for the most part. They may have some other connections in the spinal cord or other parts of your body, but your brain is grand central station to the body. Anything that needs to be done in the body needs to go through the brain. Alright? And to work properly, your brain needs oxygen. Where is oxygen carried? Oxygen is carried in the blood. The heart pumps the blood, brings oxygenated blood to the brain, and that's how the brain works. So now, the topic of this lecture. What is a stroke? So there's a difference between ischemia and an infarct. These are two terms that I'm just going to explain. Ischemia is there's a decrease of blood flow to the brain, and when there's a decrease of blood flow, you have less oxygen going to the brain. An infarct is when the tissue is dead. The brain can't function any longer. No oxygen, the tissue dies, and you have an infarct, which is also called a stroke. Now, how fast do these changes happen? They happen almost immediately, okay? Within minutes. You've heard these terms before, a TIA. One thing that I want to get from this lecture is the term mini stroke should be out of your vocabulary. A mini stroke means nothing to me, okay? You either have a TIA or you have a stroke. A mini stroke, some doctors may explain a mini stroke when they're describing a TIA, and some doctors may describe a mini stroke as a stroke that's small. I don't know. It's not a real term, and it shouldn't be used in your vocabulary. So this is the point of this talk, to try to educate you, learn the signs of stroke. And a TIA is when there's not enough blood flow going to the brain, but it lasts for a very short amount of time. Usually it's less than an hour. Most commonly it's 5, 10, 15 minutes, okay? If that persists, if there's no blood going to the brain for an extended period of time, then you're having a stroke, okay? So it's a little bit of semantics, it's about the time frame. But a TIA is basically a transient, a loss of blood flow for a short amount of time. Ischemic infarct is a blockage in one of the vessels and no blood is going to a particular portion of the brain. Okay? When no blood goes to the portion of the brain, no oxygen, you have a stroke. I do want to, and that's the significant majority of all types of stroke. 85% of strokes are ischemic strokes. That's what we're going to focus on. 15% of strokes are caused by bleeding, which is called a hemorrhagic stroke. The way that works is the blood compresses along the normal brain tissue and causes a lack of blood flow and oxygen to that portion of the brain. There are different mechanisms. We're going to talk about the ischemic stroke, which is a blockage in the artery. Okay? So here's just some pictures on the left. On the left, here's a hemorrhagic stroke where there's a rupture of a blood vessel. Here's a cartoon description. On the right, you can see in the middle of the blood vessel, there's a clot, and it's blocking one of the vessels. And as you can see, if it's blocking the vessels, blood flow is not going through, and you're going to have a stroke. All right. Here's just some basic brain anatomy. I'm not going to get too much into this. I'll let Dr. Bodu handle the vessels of the brain, okay? So now to the meat of the matter. What are the signs and symptoms of stroke? So we've discussed basically what the brain can do, what the brain does. Now you extrapolate from that, and if you have a loss of any of those functions, you may be experiencing signs of a stroke. So, sudden numbness on one side of the body, sudden weakness, drooping of the face, especially on one side of the body. In general, your left side of your brain controls the right side of the body, and the right side of the brain controls the left side of the body. Alright? Trouble seeing, trouble with vision, not being able to see half peripherally, your peripheral vision, losing sudden vision in one eye, loss of vision in one eye. Trouble speaking, trouble understanding, trouble getting words out. Very commonly, stroke patients, they'll have sudden onset where they'll understand what their family and friends are telling them, but they're almost stuttering. They can't get the words out. One of the signs of stroke. loss of balance, dizziness, loss of coordination, sudden severe headache with any of these symptoms that I've just mentioned. And what are you supposed to do if any of this stuff happens? Don't sit on the couch. Don't call your brother or sister. Don't call your children. You call 911. Okay? Time is of the essence. We're limited by the amount of treatment we could give you based on time. And we'll get into that a little bit more. We have a saying, be fast. This is to help you remember the signs and symptoms of stroke. B stands for balance. Loss of balance, sudden loss of balance. E is for eyes, sudden loss in vision. F is for face, drooping of one side of the face or any asymmetry. A is for arm weakness, it could be leg weakness as well. S is for speech, trouble understanding or trouble getting words out. And T is for time. Time is critical. Call 911. And one of the key things to all of these symptoms are these happen suddenly. These don't happen slowly over the course of 2 or 3 days. These happen all of a sudden. Eating dinner with your family, talking, having a normal conversation, watching TV. This happens in a split second. This happens all of a sudden. I do want to just specifically mention on TIA. So we said TIA was a transient ischemic infarct. A decrease in blood flow to a particular region of the brain for a short period of time. Now these tend to resolve relatively quick if it's a true TIA. Most of them resolve within 10-15 minutes. But what I don't want you to do is, I don't want you to just think it's nothing, sit back on the couch, go back to sleep, and get on with your day. A TIA should be a warning to you. It could be a blessing in disguise. It could lead you to the hospital, figure out some other diagnoses that you may have. You may have some other irregular heart rhythms, high blood pressure that may have triggered that event. And we'll put you on the right medication to try to prevent a larger stroke in the future. Okay? So if you have any of these symptoms, call 911. So we said this already, time is brain. And every minute you lose a significant amount of brain cells. Okay? It's 1.9 million. 1.9 million every minute. People talk about drinking kills brain cells, smoking kills brain cells. Well, a stroke trumps all of that. Okay? If you're not getting blood to a particular portion of the brain, every minute 1.9 million neurons and 14 billion synapses, which are the connections from each of these brain cells, are destroyed in an acute ischemic stroke. Okay? So again, time. Act fast. Okay?
What do you call it? It's acute. Acute. What's acute?
Acute means suddenly. Okay? This is just some more numbers. I mentioned by the minute we lose about 1.9 million brain cells, million neurons. If you extrapolate that to an hour, it's about 120 million, and per stroke it's about 1.2 billion. 1.2 billion, all right? I could send these slides to you if you guys are interested to have the numbers as well. And I'm going to drill this home again. 911. Call 911 right away. Don't drive to the hospital yourself. Don't wait for your loved one or family member or friend to get off of work for them to take you to the doctor. Call 911 yourself. Have somebody call 911. And we may be able to get some treatment for you. Why is time so important? The faster that we can reperfuse or open that blockage in the artery, the more chance you'll have for a better recovery, less disability, less symptoms, and more likely to have a functional outcome, meaning you'll be able to walk again. Okay? We have two main treatments for strokes. One is a blood thinner. It's called TPA. It's called Alteplase. All right? And then we have something called mechanical thrombectomy, where the surgeon or the neurointerventionalist actually goes in and pulls out the clot. And that's what Dr. Bodu will talk about in the second half. But we can give this clot-busting medication, the TPA, up until 4.5 hours. What we know for sure is the faster you get this medication, the more likely it is to break up the clot, more likely for you to recover, okay? So even though you have 4.5 hours to get this medication, if you get this medication in that first hour, where we like to say it's the golden hour in neurology, you're going to do much, much better than if you get it in the 4th hour, okay? What happens when you get to the hospital and we think that you may be having a stroke, signs and symptoms of a stroke? We're going to do a picture of your brain first. We're going to do a CAT scan, okay? We spoke about the other type of stroke, a hemorrhagic stroke, where there's bleeding in the brain. You'll have the exact same symptoms. The only way we're going to know that it's not the bleeding type of stroke is by taking a picture, a CAT scan of your brain, okay? If the CAT scan doesn't show any blood and you're having the symptoms that we described, you might be a candidate for this clot-busting medication and mechanical thrombectomy, which Dr. Bodu will talk about. Again, the goal of all of our treatments is to open up this blockage, get blood and oxygen flowing back to that portion of the brain. Okay. This is just a depiction of a cartoon of a brain. You see some vessels. You have 2 major vessels that bring blood to the front of the brain, and 1 major vessel that brings blood to the back of the brain. And I know Dr. Boldu will talk about that and give you a little bit more roadmap to the blood vessels of the brain. Okay. Why am I here? Why are we here? To talk to you guys about stroke and to tell you the importance of calling 911 and getting treatment. And we know this is a problem in the United States. Everybody knows about heart attacks. Everybody knows that if they have chest pain, they have pain running down an arm, they go to the hospital or call 911. For some reason, the memo hasn't gone out for stroke. All right, and here are some of the numbers. Less than 10% of all patients that are actually having a stroke get this clot-busting medication, TPA. And only 22%, about 1 out of every 5 patients who's experiencing a stroke, goes to the hospital within 3 hours. Now, now you're going to say, what is everyone else doing, right? Well, I mean, if you're not moving one side of your body, or you can't speak, or your face is drooping, you would think you would want to go to the hospital quick. You'd be surprised. I've seen people wait till the end of football games to come to the hospital, to wait until the end of their work day. Shabbos, you should still, it's an emergency, it's an exception. So, but I've heard all types of stories. People may not be a candidate for this clot-busting medication for the following reasons that I just said. They didn't come to the hospital on time. They may not have known they were having a stroke. They didn't recognize the symptoms of stroke, and that's what we're trying to do here, educate everybody. Okay? Recognizing a stroke is the most important thing. If you don't know to call 911 and go to the hospital, there's not much we could do after the fact. Okay? Whenever in doubt, it's safer to go to the hospital. Call 911. Call Hatzola. Hatzola works with us very closely as well. Okay. So, normally what happens is somebody's having stroke symptoms. You call 911, like we just said. An ambulance or Hatzola comes to you, and they take you to the hospital, right? There's different types of hospitals. There's hospitals that have the capability to take out this clot, like we just said with mechanical thrombectomy. All hospitals are able to give this clot-busting medication, TPA. But wouldn't it be great if we could somehow give this TPA and clot-busting medication before the patient even gets to the hospital? Think about how much time it takes from the time an ambulance comes into somebody's home or somebody's apartment and gets to the hospital. It takes a significant amount of time. Wouldn't it be great if we could do it at their house? Get a picture of their head, CAT scan of their brain, give them the medication, and save some more precious time. How does that sound? Good? Sounds amazing, right? Too good to be true? We have the mobile stroke treatment unit, okay? This is something we're very excited about. We have three in the tri-state area. We have 1 in the borough of Manhattan, 1 in the borough of Queens, and 1 in Brooklyn, okay? And I'll tell you a little bit more what the mobile stroke treatment unit is. If you haven't heard about it, we've been marketing it a lot over the past year or 2. But we like to advertise it as it's basically an emergency room on wheels, okay? Anything for stroke treatment. anything that an acute stroke-ready hospital can do for a stroke patient, we could do in the back of our ambulance, okay? So here are some pictures of the inside. The first unit rolled out in Cornell in Manhattan in October 2016, and we've been collecting data on all the patients that we've treated since then. In 2017, in April, we had the Queens unit. We have one in our very own borough. And in May of 2017, Brooklyn launched. Okay? And up for our studies that we've been collecting all the data, we've been able to give this clot-busting medication, TPA, or Alteplase, up to 40 minutes faster than a patient who comes to the hospital by a conventional ambulance. Now, 40 minutes sounds like a decent amount of time. It's a show and a little bit of another show, right? But in terms of brain cells, 1.9 million brain cells per minute times 40, it's a lot of brain cells, okay? This could be the difference of somebody walking and being in the bed for the rest of their life. This could be difference between somebody understanding their children and communicating with them and not. Okay, so 40 minutes is a significant amount of time. Okay. The point of the mobile stroke unit, again, is to bring the hospital expertise to the patient. On the ambulance, you can see we have a portable CAT scan machine, which is that donut-looking thing over there. On the top picture, we have a fake patient demonstrating how they would be getting a CAT scan right in the ambulance. Okay, we actually pull over to the side of the street. The crew stops traffic on the road because the cars passing by actually creates some frequency and artifact. It takes about 3 to 4 minutes to get a picture of the brain. We'll see if there's a bleed or not. If there's no bleed, we think there's an ischemic stroke. We'll give them medicine right there in the ambulance in the street. Okay? Like I said, there's 3 running in New York City, Manhattan, Queens, and Brooklyn. The hours of operation are 9 to 5, Monday to Friday. This is all funded by donors, okay? This is all donor money. It's not reimbursed by any of the insurances yet, but don't get scared. You won't get a big bill if you get picked up by one of these units. It's all fully covered by philanthropy, the ambulance, the medication, all the treatment you would get before you get to the hospital is all covered by donor funds, philanthropy. The future, we're hoping for this to be accepted by insurance. Once insurance starts reimbursing for these, we're hoping you're going to see a lot more of these units in the streets. We've already proved that we could give the treatment about 40 minutes faster. Now we have to prove that it's cost effective. Okay? So the mobile stroke unit, it's a full house. There's a lot of people on there. It's very different than a regular ambulance. Some basic information is there's 2 general types of ambulance. One called a BLS unit and one called the ACLS unit. It's a little bit, ACLS is more advanced, you have paramedics on there, but they both only have 2 people on board, 2 paramedics. What we have is a registered nurse on board who's mixing medications, administering medications. We have a CAT scan technician who needs to control the CAT scan machine and take a picture of your brain, okay? And we have either a Cornell or Columbia stroke neurologist, board certified vascular neurologist. I am one of the 4 neurologists that is seeing these patients in the ambulance, and what happens is we have telemedicine, which is they're looking at us at a screen, there's a camera in the ambulance, they're seeing my face, I'm seeing them, and we're having a direct communication. The ambulance is basically an extension of the ER, they're registered to the hospital, we put in orders for medications and CAT scans, just like they were in the emergency room, so hence the extension of an emergency room. Other things that we have on board that regular ambulances don't have is we have some more blood pressure medications. If you, God forbid, happen to have the hemorrhagic stroke or the bleeding inside your brain and we want to lower your blood pressure quickly, we have the ability to give some more medications that a standard ambulance would not. Obviously the TPA, and we could also check some other things in your blood that a standard ambulance cannot. Something called your INR, or how thin your blood is if you're on a certain medication. Okay. Okay. So this was, I just wanted to bring this to your attention. This was a bunch of different studies done throughout Europe and the United States, talking about stroke treatment. And the point of this is that OTT, onset to treatment, was 72 minutes. And out of all of these other studies, it was faster than any other stroke protocol. The reason is because this is the only thing that we're giving them medication before they even get to the hospital. So we're taking away a lot of time there. We're not the only one that is lucky enough to have one of these mobile stroke units. It actually started in Germany. Germany was the first unit in Europe. Europe had a couple more. In the United States, Houston actually happened to be the first one in the United States to have a mobile stroke unit. New York was the first on the East Coast, and we're the only one in the entire United States who has 3 of these units. This might be a little bit too small for you to see, but I'll mention them out loud. These are the numbers for all of our different units. I'll mention the total numbers of how many patients we've treated so far. So we get a lot of dispatches, meaning that fire department or 911 tells us to go to the patient. Sometimes we get canceled on the way going over there. They figure out it's not a stroke. We made contact with a significant amount of patients, 640 patients. We've transported about 300 patients to the hospital, and we have given this TPA, this clot-busting medication, over 100 times so far since October 2016. It's 112 times. So that's 112 patients who's getting this medication at least 40 minutes faster than if they came to the hospital. This is just a chart showing how our volumes are rising since we started. The more people who know about the mobile stroke unit, the more people who know to call 911, the more people who know about signs and symptoms of stroke, the more people we can help.
So I'm sorry, who determines whether you go to the hospital with a regular ambulance or they call the mobile stroke unit?
Good question. So it's through 911. When you call the 911 dispatcher, they have a series of questions that they're going to ask you. If that 911 dispatcher feels that you're having a stroke, they're going to call our unit and they're going to send us to your site if we don't have another patient on board. Okay? The other way you can get this unit is if another ambulance comes to your house and those paramedics feel that you're having signs or symptoms of stroke, they can request our unit there as well. Okay? What was that?
They should be able to get you to the hospital faster than calling a unit which may be in Far Rockaway and you live in Long Island City.
It may or may not. If it's less than 20 minutes, we're going to go to the site. If it's less than 20 minutes for us to get there, we're going to go there because we've been giving, once we arrive, we've been able to give this medication up to within 15 minutes was the fastest we've given it. So that is still going to be faster than the hospital. Additionally, the benefit of coming on the unit is you have the benefit of a vascular neurologist. You have a stroke neurologist looking at you before you even get to the hospital. If you have something called a large vessel occlusion or a blockage in a major vessel in your brain, we alert the hospital and let more staff know that you're coming to do more things about it, which Dr. Boldu will talk about. Okay?
You said that if you call 911, they have a charge and so on. What happens if we call Hatsola? How does that work?
They're part of a different system. Our stroke ambulance won't come through through Hatsola.
So that's a very important point. It's a very important point.
Hatsola, I believe, is a private.
I would call Hatsola first.
Yeah.
Normally, Hatsola is quicker and I would think faster than a regular ambulance. But for the stroke ambulance, this operates through the Fire Department of New York. This is through FDNY. We have to follow the FDNY protocols. Okay?
So if we know that someone's having a stroke or whatever, right, then we should not call really Hatsola for this one at this time, but 911 since they have a special unit.
I would agree with that, yes. You're not going to get the mobile stroke unit by calling Hatsola.
Okay.
Even if they get there and they know you're having a stroke.
So Hatsola can request us to be added on. Since we rolled out in Queens, I haven't seen Hatsola request us onto a call.
Maybe just because we're 2 minutes from the hospital.
Yeah, that's the other.
Quite possibly. You're down the road. You're down the road.
Right.
I have a few more slides. Let me get through it, and then I'll take more questions. Okay. Just one of the other things I want to mention is one of the nurse on our Queens unit in our community actually won an award from New York State EMS Nurse of the Year. So you have an EMS Nurse of the Year, who's the nurse on the ambulance in your borough. Like I said, this is a collaborative effort. Cornell didn't do this by themselves. New York Presbyterian didn't do this by themselves. It's with the fire department, some other organizations called REMAC, REMSCO. There's regional leadership at each hospital. This was years and years in the making. And I'm going to end with this. This is no longer a secret of mine because Montel Williams went on TV and spoke about this. But Montel Williams was a patient of ours. He actually ended up having a hemorrhagic stroke, which you could see in this middle picture. The bright little ball-sized dot, ball-sized hyperdensity, which is what I would call it, is actually blood in the brain. He was working out in a gym on the Upper West Side. He called the ambulance. We actually happened to be down the block from him. And we took a CAT scan of his brain. We saw that he had bleeding in his brain. We could not give him the clot-busting medication, but what we did do is treat his blood pressure. We gave him antihypertensives. He actually went on Dr. Oz show. He was on Good Morning America. And this was a quote from him that saved my life. I would have bled out on the spot. And that's regarding the MSTU. And this was in October, not too long ago. Alright, and that's where we're going to break, and we'll lead it to Dr. Bodu. If you have a few questions, I'll take another 1 or 2 questions before the end.
Okay, where are the locations in Manhattan and Brooklyn?
So we cover the entire borough of Manhattan, entire borough of Brooklyn, and entire borough of Queens. So they could be anywhere in the borough at any particular time.
But they're not settled like you are settled in the Queens version of...
The New York Presbyterian one, it leaves in the morning at 9 a.m. and comes back to New York Presbyterian Queens at 5 p.m. But throughout the day, it could be anywhere in Queens. It could be by the airport, it could be by LaGuardia, it could be by JFK. We've been to Rikers Island once with the ambulance, actually. It could really go anywhere.
So this means if you are not far away from the hospital, you may be better off to go with a regular ambulance than waiting for them to come from God knows where.
So that's similar to the question the other lady had. If you're about 20 minutes from where we are, which with lights and sirens on an ambulance, you could get to a significant portion of Queens in 20-25 minutes. But if you're more than 20 minutes, we're gonna tell the other ambulance, you guys should go to the hospital, don't wait for us. So.
Is CPA something you could recommend to be part first aid kit